All right. Hi, everybody. It's a privilege to be with you this afternoon, and thank you so much to the MRA for inviting me to kick off this really important session. Oh, you can see my slides, but I can't see my slides. All right. There we go. Great. Fantastic. So I am Allison Betof Warner. I am the director of the Advanced Melanoma program at Stanford and the director of solid tumor cell therapy. And again, truly a privilege and an honor to be with you this afternoon. Can't get the clicker to work. Sure. There we go. Great. So I just want to give us a little bit of a walkthrough of where we are, where we've been, and most importantly, where we're going at this really exciting time for melanoma research. So if you came to one of our clinics anywhere in the 1990s, the early 2000s, and really anywhere until 2011 when ipilimumab was approved, the standard of care was to get chemotherapy, and the average survival that we would quote to a patient was about 6 months. We all know that the incorporation of standard immune checkpoint blockade has dramatically revolutionized both melanoma and many other cancers out there. And just as an example, these are data from the Checkmate 067 study, which was the confirmatory study for the use of ipilimumab plus nivolumab for melanoma. And from this, we see that from a median overall survival of about 6 months to patients, after the approval of ipilimumab plus nivolumab based on the Checkmate 067 study, we saw a median overall survival of 72 months with the approval of these drugs. We moved that bar tremendously in a reasonably short period of time with the approval of these agents. What I'd like to say is that was a huge step forward and monumental in our field, and yet we still have a really long way to go. What about all of these patients that we are not treating and curing with these drugs? And that's really where I want to focus today. So just to make sure we're all on the same page and starting from the same place, let's talk about where we are with melanoma. These are 2024 numbers, but over 100,000 Americans will develop invasive cutaneous melanoma. That is more men than women, of course, and the median age is about 65 years. Lifetime risk of a melanoma diagnosis is about 2.6% for non-Hispanic white people, about 0.1% for Black people, and about 0.6% for Hispanic and Latino people. It's the 5th most common cancer, and I think many people don't recognize quite how common a diagnosis of invasive melanoma is. It's about 5 to 6% of all cancers. And the incidence has decreased slightly in younger people, but is increasing and continues to increase in men over the age of 55 and women over the age of 45. That is driven in large part by a high number of thin melanomas and melanoma in situ being diagnosed, though the absolute number of thicker and very high-risk tumors is also still increasing. If we think about the mortality of this disease, so over 8,000 Americans will die of invasive cutaneous melanoma. There have been, as we've said, significant reductions in mortality, particularly these data are from 2014 to 2018, most predominantly in non-Hispanic white people. And that overall mortality decreased from 2013 to 2016 by almost 18%. Unheard of in the field of oncology. And that is clearly driven by the approval of these newer agents, both immunotherapy and targeted therapy agents. Of course, early detection of thinner melanomas remains critical to reducing mortality. We don't want any of our patients to need medical oncologists like me, but developing better approaches for advanced disease remains a cornerstone of improving these mortality numbers. So this is a slide that I've borrowed from my friend and colleague, Dr. Hussein Taubi, but these are the approvals for melanoma, and the options continue to grow year after year. Of course, starting with chemotherapy in 1975 with the approval of dacarbazine, IL-2 in the late 1990s. We mentioned ipilimumab in 2011, followed by targeted therapy with vemurafenib, trametinib, and then dabrafenib. The approval of checkpoint inhibitors, pembrolizumab, followed by nivolumab, and then, of course, combinations of both targeted therapy with dabrafenib and trametinib, vemurafenib, cobimetinib, and then subsequently encorafenib and binimetinib, as well as, of course, nivolumab, ipilimumab. T-VEC as the first oncolytic virus is an injectable in 2015. 2020 saw the first combination approach, which was atezolizumab combined with targeted therapy. And then 2022, major breakthrough with the approval of a new checkpoint inhibitor combination with relatlimab plus nivolumab, so a PD-1 plus a LAG-3 agent. And of course, huge breakthrough that occurred right around the time of this meeting last year, which was the approval of lifileucel, or the first TIL therapy for melanoma. And we'll talk a bit more about that today. So to highlight some of the great improvements that we saw in 2024, I'm going to start by talking about neoadjuvant therapy, and particularly the NADINA trial that many of you have heard about, and I know many patients come to my clinic asking about NADINA and neoadjuvant therapy. We'll highlight some of the 10-year survival data that we saw updated this year for immune checkpoint inhibitors, the first real landmark to see 10-year survival data in this disease. We'll talk about long-term survival data that just came out last week for patients with melanoma brain metastasis, and then the FDA approval of TIL therapy with lifileucel. So to start, neoadjuvant therapy. So many of us know that for patients until very recently, for patients who were diagnosed with thick, high-risk melanomas, these patients underwent a surgery followed by a lymph node or surgery with melanoma excision and a lymph node excision. For high-risk patients, patients then were often prescribed 1 year of adjuvant PD-1 drugs, either nivolumab or pembrolizumab. And this has reduced risk of recurrence significantly. Over the last several years, we've really seen great interest in trying to give immunotherapy pre-surgery, so-called neoadjuvant therapy, with the goal of doing many things, one of which is to try to assess the response of the tumor when we take it out to see if that immunotherapy is working well and decide what treatment a patient should get post-surgery. Additionally, the goal is to hit any small number of circulating or escaping melanoma cells as early as possible to try to minimize any risk of spread and contain any already metastasized melanoma cells. This also gives us tremendous opportunity to study these tumor samples and understand why certain patients respond to checkpoint blockade and others do not. And so there's been a huge push towards using neoadjuvant therapy for patients who have a clinical stage 3 disease or a lymph node that is apparent at the time of diagnosis, as well as patients who have in-transit metastasis at the time of diagnosis, but still have resectable melanoma. So first, we saw S1801, which was a beautiful randomized study of pembrolizumab given pre and post-surgery, randomized against pembrolizumab post-surgery. And we saw significantly better outcomes for patients who'd got 3 doses of pembrolizumab pre-surgery. That pretty quickly was incorporated into our routine care for many patients. And now we have seen presentation earlier in 2024 of the NADINA trial. So the NADINA trial was a phase 3 randomized trial of neoadjuvant nivolumab plus ipilimumab, 2 doses of that combination followed by surgery, versus adjuvant nivolumab, so going to surgery and getting 1 year of adjuvant nivolumab. And this was in patients with macroscopic resectable stage 3 melanoma, so again, palpable lymph node or clinically apparent lymph node, and or in-transit metastases that were still resectable. These patients were randomized 1-to-1 to either this ipilimumab plus nivolumab treatment or straight to surgery followed by nivolumab. For the patients who got ipilimumab plus nivolumab pre-surgery, patients then underwent surgery, and at the time of surgery, we asked our pathologists to assess how well that tumor responded to the immunotherapy. If there was 10% or less viable melanoma, if 90% or more of the melanoma had been killed by the neoadjuvant therapy, we actually stopped treatment in the NADINA trial. If there was more than 10% viable melanoma, then patients went on to receive adjuvant therapy. For patients who had a BRAF mutation, that was a year of adjuvant BRAF plus MEK therapy. For patients who do not have a BRAF mutation, they got finished the year of adjuvant PD-1. And you can see two separate curves on this slide. So this first is event-free survival, and the right is distant metastasis-free survival. So we'll talk through event-free survival first. So that was essentially patients who did not have recurrences or death from their melanoma on this trial. And you can see blue are the patients who got ipilimumab plus nivolumab pre-surgery. The red was the adjuvant nivolumab only, and higher is better, right? More patients without this poor outcome. And so significantly better outcomes for patients who were treated with this neoadjuvant ipilimumab plus nivolumab. We know that most importantly, what we need to suppress with our treatment is distant metastasis, right? Local recurrence is certainly a bad outcome. We have to put patients through surgery again. But what drives most of both the morbidity and the mortality of melanoma is distant metastasis. So distant metastasis-free survival has become a critical outcome when we think about early stage melanoma. And again, looking at the blue ipilimumab plus nivolumab versus the red nivolumab adjuvant arm, we see significant improvements in distant metastasis-free survival with this, what we call the NADINA regimen, or 2 cycles of ipilimumab plus nivolumab pre-surgery. If we break this down by patients who have what we call a major pathologic response, meaning they have that 10% or less living melanoma at the time of surgery, we know that patients who achieve that outcome have truly excellent clinical outcomes. We've seen that from the early data with pembrolizumab in the S1801 trial, and now again in this NADINA trial. Now, I will caveat that by saying that this is only 18 months of follow-up that we have seen from NADINA. These are young data. We're going to need to see them mature over a period of years. But thus far, for patients who achieve this either complete response, meaning no viable residual melanoma at the time of surgery, or major pathologic response, 10% or less viable, you can see here from both the recurrence-free survival and distant metastasis-free survival curves, really excellent outcomes, at least at this 18-month mark, and we expect these to continue based on historical data. So as of October 9th, 2024, neoadjuvant nivolumab plus ipilimumab was approved in the Netherlands as a standard of care. So it's actually the first country to do this. And neoadjuvant immunotherapy is increasingly being accepted as a standard of care in many countries around the world. And in fact, in 2024, we saw 3 neoadjuvant regimens incorporated into what we call the NCCN guidelines, the standard guidelines for the treatment of melanoma. So huge steps forward with neoadjuvant in 2024. I'm going to move on next to the 10-year survival data with immune checkpoint inhibitors for metastatic or advanced disease. So the first was KEYNOTE-006. So KEYNOTE-006 was the trial of pembrolizumab versus ipilimumab for advanced melanoma. And at the European Society for Medical Oncology conference, Dr. Caroline Robert presented the first 10-year follow-up from this trial. You can see the overall survival on the left and the melanoma-specific survival on the right. When we talk about 10-year follow-up, we have to acknowledge that many of our patients, as a good outcome for melanoma, live long enough to have other things that may cause mortality. So overall survival at 10 years for patients treated with pembrolizumab was 34%, and ipilimumab was 23%, but the melanoma-specific survival was 45% at 10 years with pembrolizumab alone. That number is not nearly as high as we would like it to be, but think about where we were with a diagnosis of melanoma with a median survival of 6 months to having 45% of our patients alive with 10 years with PD-1 alone. That brings us to Checkmate 067. As I mentioned, this was the trial of nivolumab plus ipilimumab versus nivolumab alone versus ipilimumab alone. And also at that same conference, in the next talk, we saw Dr. James Larkin present the data from this trial with, again, 10-year survival follow-up. Overall survival, again, on the left, melanoma-specific survival on the right. And you can see 10-year overall survival in this trial, patients treated with ipilimumab plus nivolumab in orange here, 43% alive at 10 years, and 52% 10-year melanoma-specific survival. More than half of the patients treated on this trial that were treated with ipilimumab plus nivolumab were alive at the 10-year mark. Huge milestone. Again, not nearly where we want that to be. We want that to be 100% of our patients. But recognizing how far we've come and really taking this as a moment to celebrate the accomplishments of the many brilliant scientists, physician scientists, and clinicians who came before us and really laid the foundation for this. One thing that we did learn from this trial that I have routinely started using in my clinic already is we've been looking, patients ask us, so how do I know? How do I know when I'm in the clear, right? How do I know when to start breathing again and taking deep breaths? We hear this all the time, and we feel it for you. We want to be able to give you that answer. And so one thing that we saw from the Checkmate 067 study was that patients who had made it to the 3-year mark and their melanoma had not progressed by that time point is an excellent surrogate for long-term survival. So those patients who made it to that 3-year mark without progression of their melanoma, 96% of them were still melanoma, surviving from a melanoma perspective at the 10-year mark. So again, when we see patients hit that 3-year mark, we really can tell them, there are no guarantees in the world, but we can probably take a really nice deep breath. And that, I think, is a beautiful piece of data that I've started really incorporating routinely with my patients. All right, this is hot off the press. Paper literally just came out about a week ago. But melanoma brain metastasis is one of the dreaded complications that we'll talk about all throughout this weekend and is a main area of my research. And so to see data from long-term survival in this patient population really is a huge accomplishment. So just so we're all on the same page, melanoma has one of the highest risks of metastasis to the central nervous system among any of the common solid tumors. And unfortunately, patients with melanoma brain metastasis are excluded from nearly every clinical trial. And that is sometimes for safety reasons and sometimes for other reasons, practicality and otherwise. But it is exceptionally difficult to study these patients and their long-term outcomes because we do not have the same degree of clinical trial data in patients with melanoma brain metastasis. Prior to the approvals of immunotherapy and targeted therapy, the median overall survival for patients diagnosed with melanoma brain metastasis was about 4 months. Recently, as in last week, Dr. Georgina Long and her colleagues presented and published data in Lancet Oncology from the ABC trial. And this was a randomized trial that was conducted in Australia there was a phase 2 trial of nivolumab plus ipilimumab randomized to nivolumab for patients with asymptomatic melanoma brain metastasis. There was a separate cohort of patients who had previous intracranial treatments, but focusing on what is the vast majority of our patients, you can see here in red the patients treated with ipilimumab plus nivolumab, and in blue the patients treated with nivolumab only. Intracranial progression-free survival is the marker that we generally talk about here. So did patients actually have their melanoma progress specifically in the brain? And you can see even out to the 7-year mark, clear improvement with ipilimumab plus nivolumab. And following this trial as well as the Checkmate 204 trial, which was a similar trial conducted in the US, that was a single-arm trial, really ipilimumab plus nivolumab became the standard of care for melanoma brain metastasis and remains the standard of care for melanoma brain metastasis. But if we look at the overall survival curves, I will just highlight this. At 7 years, we can see still an ongoing plateau of the curve, meaning our patients are still doing well. That curve is not declining, their mortality is not increasing. And a median overall survival of 64 months, greater than 5 years for patients with melanoma brain metastasis. Again, not where we ultimately want to be, but a huge step forward for our field, and I think very reassuring for our patients who are diagnosed with melanoma brain metastasis to know that there are these long-term survivors who are doing exceptionally well who were treated on this trial. Now, this is a very small number of patients, and we are continuing to see patients treated in the real world, and we will have these data mature, but from these early trials, it's really reassuring to see these long-term data. All right, and then we will talk last of the 2024 highlights about the FDA approval of TIL therapy. If you were here with us last year, you heard us celebrate this. This was right after the approval, and everybody was very, very excited. But we'll highlight some of what has happened in 2024 in this field as well. So lifileucel, which was the first FDA-approved cell therapy for any solid tumor, is the name of TIL therapy that has now been approved for patients who progressed on standard immunotherapy, and for patients who have a BRAF mutation were required to have also been treated with targeted therapy. So this is refractory patients, and we can see from what was called a waterfall plot, anything that is going downwards here means the tumor is shrinking, anything going upward means that the tumor is growing. And this was from the C-144-01 trial, which was the trial that led to the approval of lifileucel. You can see that 31.4% of patients had their tumor shrink past a certain point, which is 30% or more shrinkage, and that's what we call the objective response rate. Probably most importantly, we see that 78% of our patients had their disease controlled, that DCR, disease control rate, meaning stabilization of their disease or shrinkage, or it went completely away. To this one-time treatment, the median duration of response was not reached. So these patients are not coming in and getting treated every 2 weeks or 3 weeks or 4 weeks or 6 weeks. This is a one-time treatment. And the median overall survival in this trial for refractory patients was 14 months. Similarly, we saw a randomized trial conducted in Europe at several centers in Europe of TIL randomized to ipilimumab for patients who had progressed on PD-1. And you can see TIL here in red versus ipilimumab in black, progression-free survival, and you can see significantly improved progression-free survival in the patients treated with TIL versus ipilimumab. That's quantified here on the right, so progression-free survival 7.2 months versus about 3 months for ipilimumab. And the response rate in this trial was 49% to TIL versus about 21% to ipilimumab, including 20% of patients treated with TIL who had what we call a complete response, or all of their melanoma was gone on their scans. Now, why is that different from the C-144-01 trial? Why is that number significantly higher? There are potentially several reasons, but most likely, these patients were treated immediately after progression on a PD-1 drug. They didn't have 5 or 6 or 7 treatments in between, and we were treating patients really as quickly as possible after progression on standard immunotherapy. And so this has really driven a push to treat these patients as quickly as possible with TILs, if that is the route we are going to go, following progression on frontline checkpoint blockade. So February 16th of 2024, the FDA approved lifileucel for refractory melanoma. And I'll just take a second to give our team a gigantic shout out. So this was February 20th, just days later. That middle picture is our team at Stanford doing the first surgery to harvest TIL. And on the far right, that's a picture of Dr. Wen-Kai Wang from our bone marrow transplant cell therapy service and myself infusing the first commercial dose of lifileucel on April 4th of last year. So we were thrilled to see this finally come to fruition at our center and many centers around the US, and for this to become a really viable treatment strategy for patients with refractory melanoma. Additionally, along with the approval, we have recognized there are many, many challenges to giving this therapy, both from a patient standpoint, which we recognize how challenging this is, as well as from institutions to be able to give this really challenging and entirely new type of therapy. And so myself and many of my colleagues, as a part of the TIL working group, came together to publish guidelines and recommendations for how to best give TIL therapy. Now, this is written for our physician and scientist colleagues, but for many of you who are interested in learning more about TIL, I put up a QR code as a link to this paper because there is a lot of information in there about who may be good candidates for TIL, what we know about TIL, and also the background as well as future directions for this. So we hope that that might be helpful to you. And I put in a link there as well to the TIL working group, which is this sort of consensus body of experts in TIL therapy. And there's quite a bit of information there, interviews, videos, to learn a lot more about TIL therapy. So this is just a recap of 2024 highlights: improvements in event-free survival and distant metastasis-free survival with neoadjuvant nivolumab and ipilimumab from the NADINA trial, 10-year survival data with immune checkpoint inhibitors, long-term survival data for melanoma brain metastasis, and the FDA approval of TIL therapy with lifileucel. So that was looking backwards. Let's talk about what we do in 2025 and beyond with your partnership as patients. So I'm going to only talk briefly about the first topic here, which is refractory brain metastasis, and I'm going to leave it to my colleagues for the rest of the afternoon to cover many of the rest of these topics. So what do we know about TIL in the brain? So we talked briefly about brain metastasis, but again, just to get us all onto the same starting point. Melanoma is the solid tumor with the highest propensity for brain metastasis, and up to 70 to 75% of patients will develop brain metastasis during the course of their treatment after a diagnosis with advanced disease. Checkmate 204 and that ABC trial that I mentioned established nivolumab plus ipilimumab as the first-line therapy for patients with asymptomatic and untreated melanoma brain metastasis. BRAF plus MEK inhibitor therapy for patients who have a BRAF mutation can be very effective, but typically has a very limited duration of response, particularly in the brain. And so there's an urgent and unmet need for trials evaluating therapies for active melanoma brain metastasis for patients who have had progression following standard immunotherapy, including PD-1. So what do we know about TILs in the brain? Well, unfortunately, not a lot. So the NCI experience, so as many of you know, TILs were developed at the National Cancer Institute by Dr. Steve Rosenberg and his group in the surgery branch. And they treated many patients over a period of about 35 years prior to these really becoming commercial trials. So the NCI experience over those many years, there were about 18 patients treated who had untreated melanoma brain metastasis. And in that period of time, 4 of those 18 patients had a complete response, and 1 had a partial response, so a response rate of about 28%, similar actually to what we have seen with lifileucel. But unfortunately, we found that this is a risky treatment. There was a significant hemorrhage in one of these patients. So as part of the TIL regimen, patients get chemotherapy prior to getting TILs. That is to prepare the body to receive the TILs. One of the complications of that lymphodepleting regimen is that the platelets can get very low, and that increases the risk of bleeding significantly. Melanoma brain metastases have a propensity to bleed even without those low platelets, and so this is a really risky proposition. Additionally, several years ago now, we saw a case report at the AACR meeting, which is a basic cancer research meeting, of a 16-year-old who had nodal metastases of melanoma and then melanoma brain metastasis, who was treated with ipilimumab and dabrafenib prior to the approval of some newer combination therapies. And that patient had a partial response to TILs at 3 months and a confirmed response at 60 months or 5 years, ongoing 7+ years post-treatment. That patient actually tolerated this treatment and, as you see, had an excellent outcome, but during the treatment had a known complication of IL-2, which is the risk of seizures. And melanoma brain metastasis increases that risk of seizures pretty considerably. So again, this isn't something we should just plug TILs into patients with melanoma brain metastasis without really careful consideration. In the C-144-01 trial of lifileucel, patients were excluded who had symptomatic and or untreated melanoma brain metastases. And in that European trial that I mentioned, that allowed up to 2 asymptomatic brain metastases that were less than 1 centimeter, isn't the majority of our patients, and had no evidence of swelling around those brain mets. Again, doesn't cover the majority of our patients who have melanoma brain metastasis. Based on this, though, we hypothesize that a modified lifileucel regimen would have clinical activity and would be feasible and safe to deliver to patients with melanoma brain metastasis. So based on this, we did a pilot trial of lifileucel for patients that fell into this category. And you can see the treatment schema here, and essentially what we did was took the standard lifileucel regimen and made a few modifications. So the first modification was to reduce the dose of the preconditioning chemotherapy to try to minimize the time that patients had low platelets. Doesn't prevent the platelets from getting low, but it does try to reduce the duration of that time to try to minimize the risk of bleeding in the brain and elsewhere. The second was to put all patients on seizure preventative medications from the start of that chemotherapy. And the last was to transfuse patients to a higher number of platelets throughout their treatment, again, trying to minimize any risk of bleeding. Other than that, the regimen looked like the standard lifileucel regimen. So I started this trial when I was still at Memorial Sloan Kettering, and I will give a huge shout out to my colleagues, Dr. Alex Shushtari and Jim Smithy, who continued this trial after I left. We enrolled 10 patients from December 2022 to January 2024, and this was done as a feasibility trial. Can we get patients through this treatment? And in fact, 8 out of the 10 patients who underwent a surgery to harvest TILs did in fact receive their TIL infusion, and that met that feasibility endpoint. There were 2 patients who did not receive their infusion, both due to rapid clinical progression, and it was not safe to give cells at that time. Both of those patients, unfortunately, had more than 20 brain metastases at the start of the trial and were high risk. And so now knowing that, we think that that probably is not the right patient to treat. But the other 8 out of the 10 patients did in fact receive their TIL infusion. 9 out of 10 patients had successful manufacturing of their TILs. The average number of days, median number of days, from consent in the trial to infusion of cells was 58 days. From the surgery to infusion of cells was 42 days. And the median number of doses of IL-2 given was 4. 4 out of 6 planned doses. And in fact, that mimics what we see for patients who do not have brain metastasis. So suggesting really that these patients can tolerate this treatment quite well with the modified regimen. We saw 2 out of those 8 patients have partial responses of their melanoma in the brain. And you can see that both of those patients actually had their melanoma shrink. Both of those patients are alive today and doing quite well. One did undergo a surgery. That patient that you can see at about 50 weeks there did undergo a surgery for a slight growth of their tumor, but is now doing well and has no evidence of melanoma in the brain or the body. And the other patient also underwent treatment and is doing well and alive today. Another 2 patients had stable disease, so that disease control rate of 50% for these 2 out of 8, for these 8 patients who did receive their cell infusion. Most importantly, right, the goal of this trial was to demonstrate feasibility and safety. There were no treatment-related grade 5 toxicities, meaning no deaths related to treatment on this trial, no unexpected adverse events, no seizures, and no intracranial bleeds on this trial. And the safety was really consistent with exactly what we know for standard TIL therapy. So we are now expanding this trial and looking forward to really trying to dive in further into the safety and potential efficacy of this regimen for patients with melanoma brain metastasis, and more to come, so stay tuned. I will just also give a shout out. There was a similar pilot trial that Dr. Shushtari and I and Dr. Smithy conducted For metastatic uveal melanoma, this is now also expanded to include a form of sarcoma. And the 10 uveal patients on this trial have now completed accrual, and Dr. Shushtari actually is going to present data at this meeting from that uveal trial, so I won't steal his thunder. But more to come there as well. So we talked about brain metastasis as an ongoing gap, an area of opportunity. I just want to highlight a few others, mostly to set up my colleagues and also to generate conversation of what do I see as some of the biggest gaps, but also opportunities for us in 2025 and beyond. So the first is rare melanomas. We talked just a second ago briefly about some work in uveal. There is much more going on that I don't personally have time to cover, but you'll hear more from my colleagues this afternoon. Novel therapeutic options. Lots that has come and is to come even in 2025 in oncolytic viruses and cancer vaccines. Ongoing work with bispecific T-cell engagers and targeted therapies, and particularly for targeted therapies that target mutations other than BRAF, right? Thinking about how do we target NRAS and other really difficult mutations in melanoma. More to come from my colleague Dr. Hamid in cell therapy with engineered TILs and TCR T cells. And then we'll hear some this afternoon about preventing and managing toxicity of therapy. We know that while we're developing more and more aggressive therapies, that comes with the risk of more and more side effects, and that is not lost on us. And many of our colleagues and myself, we are working very hard to figure out how to be more aggressive against the melanoma while sparing both the normal tissue and the patient at that time. Additionally, you'll hear from Dr. Halpern about utilizing technology to improve early detection, and I think this is coming back to what I spoke about in the beginning of my talk, right? Recognizing that the earlier we can catch melanoma, the hope is, again, please put me out of work. I can happily find something else to do if we can detect melanoma early and we don't need as many advanced treatments. And then last is a panel today led by Dr. Schuchter, keeping the focus where it belongs, which is on you, on the patient and your experience, and how do we improve outcomes for patients. So with that, I will say thank you to, first and foremost, our outstanding melanoma and cutaneous oncology team at Stanford, as well as my many collaborators there and our cell therapy group who have made the TIL work possible. My collaborators and friends at MSKCC and Weill Cornell, and particularly, as I mentioned, Dr. Alex Shushtari and Jim Smithy, who really partnered with me to ensure that this brain metastasis trial finished after my move from MSK to Stanford a couple years ago, and to all of our sources of funding, and particularly to the MRA for bringing us all together and giving us this opportunity to talk about exciting work in the field. And with that, I'm happy to take any questions that you have.
Can you all hear me? All right, we actually have a question from online. The chat is really enjoying your talk, Dr. Betof, especially the promise of immunotherapy. One of the individuals is wondering, how do holistic practices like exercise and diet play a role in this? I know you have a special interest in this, so I thought it would be a great question.
Oh, question right after my own heart, thanks. For those of you who don't know, I spoke at a patient forum, I think about 2 years ago here about exercise and immunotherapy. So this was actually the area of focus of my PhD work many years ago, and a topic near and dear to my heart. So I'll start, though, by talking about diet, because that's actually where there's more data. This is very complicated. We don't have exactly a measure of, the immune system goes up, right? I don't have a way to measure that. So it's not as simple as saying, eat this, and therefore the immune system is more active, right? This research is quite complicated. But I think the biggest area of research that we have seen and the strongest data that we have seen for diet is related to fiber intake, and that has come out of the group at MD Anderson, Dr. Jen Wargo, Dr. Jen McQuaid, showing that high fiber intake really may help increase an immune response and work well with immunotherapy to make immunotherapy more effective against cancer. When we talk about high fiber, people ask me what the magic number is. How many grams of fiber do I need to track on my, diet app per day? We don't have a hard answer to that right now. Dr. McQuaid and others are conducting actually a randomized trial at MD Anderson, trying to dive into that a little bit deeper. But what we do know is that high fiber intake is something that is safe and something I do routinely recommend to my patients. When we talk about fiber, I always tell patients that that does need to come from your diet, not a pill, not a fiber supplement. And the idea behind this is that high fiber intake promotes healthy gut bacteria and a diversity of gut bacteria. And what we're really looking for is that diversity. So if we take a fiber supplement, unfortunately that's 1 or 2 or 10 strains of fiber that promotes a small number of bacteria and causes those bacteria to take over the gut. What we really want is that wide diversity of gut bacteria that helps your immune system recognize self versus foreign and help to attack the cancer. And so this really does need to be dietary fiber. And so, shooting for that high fiber diet, I think, is one of the best recommendations that I can give to people. When we talk about gut microbiome, I'm going to take this as an aside since the question was more broad about holistic treatments. When I talk about gut microbiome, people inevitably then ask me, should I take a probiotic? And the data there, again, out of the MD Anderson groups really suggests that that is potentially harmful, again, because that can promote a small number of gut bacteria, certain strains over others. And what we're really looking for, again, is that diversity of gut bacteria. So you're going to have to do the hard work and actually eat a good diet of diverse foods. When it comes to exercise, the data are not nearly as strong yet. Some of us are working on this. What we know from other cancers is that at least in animal models and then correlative from humans reporting their exercise, is that exercise really can slow cancer growth. And we have data for this in melanoma and many other cancers, 22 plus other cancers in mouse models and any number of human studies as well from correlative data. What we don't know is exactly why that works. And my lab and others are really diving into that. We've shown that, modification of tumor blood vessels, so, we all know patients with heart disease get prescribed exercise, right? Why is that? Well, one of the reasons is that exercise helps the blood vessels in the body be stronger and sort of solidify their structure, and therefore that helps patients with things like heart disease and diabetes. Well, as it turns out, tumor blood vessels are really abnormal too. They tend to leak, they don't do exactly what they're supposed to do, they don't go where they're supposed to go, and we get pockets of tumor that are very hypoxic or don't get enough oxygen and nutrients. While that sounds like that might be a good thing, what that actually does is drive the tumor to say, I gotta get out of here, right? I don't like this, there isn't enough of what I need, and drives a metastatic phenotype of that cancer. And so as it turns out, improving blood vessels in tumors actually makes them more responsive to cancer therapies, and we've shown this in animal models. So I suspect that that has something to do with why exercise may work well with immunotherapy. Now, if you ask me exactly how much, what kind, any of those things, we do not have human studies that help to answer that for us yet. What we fall back on are the recommendations actually from ASCO and the American College of Sports Medicine, which is essentially the recommendations across all cancers. So 75 minutes per week of vigorous intensity activity, that's really like 15 minutes a day, 5 days a week, right? Or 150 minutes per week of more moderate intensity exercise. That can be something as simple as walking. Again, 30 minutes a day, 5 days a week is 150 minutes. And then we do recommend adding 2 to 3 strength sessions a week. That does not need to be lifting heavy barbells. For those of you who know me, I'm a CrossFit coach. I highly encourage lifting heavy barbells, but that doesn't have to be you, right? That can be resistance bands, anything else that helps maintain your muscle mass. And that's really to improve quality of life and potentially quantity of life for cancer patients. So a long-winded answer, but a complicated question that there isn't really strong data for yet.
I think we might be out of time for this session. Do we have time for one more? Okay. Do you want to ask?
Okay, I'll try to be brief. Thank you very much, Dr. Warner. I have like a lot of questions because I've been in this world since the end of September of 1998. You were very, very young then. But two questions. First of all, in gathering this data on the extended survival, how standardized is the surveillance and what are the methods that are being used? Because that could influence the data set you're collecting. And how are you trying to differentiate the good responders from the non-responders? Obviously, I am very much an outlier in the good responder side, so I've been wondering about this question for a long time. But there's an important question here that actually could be very, very helpful.
When you say differentiate, you mean sort of before treatment, trying to figure out who is more likely to do well? Or?
Well, you've got sets from these trials of people who responded and people who didn't.
Yep.
Okay. How do you, going forward, you want to be able to better select the ones who are likely to be the good responders. Okay, how are you going about trying to move that forward?
100%. So I'll answer the first question first, and I'll get to the second one, although I'll tell you that there's an entire talk on resistance this afternoon and actually how people are studying that. My lab and many others are actively working on that from trials as well as our standard of care patients. So from these trials, when we design and write these trials, we write set intervals where we will follow a patient closely with scans, and then what we call survival follow-up. And each trial does this a little bit differently, but generally that is, a plan to call a patient and check in at set intervals. Now, of course, you can imagine patients are lost to follow-up in trials. The ones that do well, like as we hope everyone does, some will go out and we will not be able to find them because they're living their best life somewhere where we don't know where they are. That being said, I will say that the follow-up in these trials, even out to 10 years, and the rates of follow-up, I don't have them quite off the top of my head, but were actually excellent. And I think part of that is that this was such a huge breakthrough in our field, and patients were so thrilled to be a part of these trials and to have the opportunity to have these drugs at a time where they were not available, that to all of your credit, patients have made themselves very available to participate in this follow-up, so these data are available. But what I'll tell you is that this is a pre-specified plan that goes into most clinical trials like this, that later stage trials. And we put a lot of effort into finding patients over the long term to be able to keep track of these survival numbers. It's not perfect by any stretch of the imagination, but we really do work very hard to find patients and to track them down. And we are grateful to all of you who make yourself available for that survival follow-up so that we can get data like these and to reassure our patients with them. In terms of the resistance question, or why do certain patients respond and others do not, as many of you know that have participated in trials, we often ask for biopsies during trial and post-trial. How do we learn how patients respond to treatment or don't? It's by studying their tumor. And there isn't really a good way to do that without biopsies. We recognize, we truly do what we ask of you when we ask you to get a biopsy, particularly when a treatment doesn't work, right? That is a very challenging moment for us and for you to ask you to then go through a procedure. But the only way that we can learn why these treatments work or don't work is to look at the tumor and to try to study that. And you'll hear some of that this afternoon from my colleagues in the resistance session who will tell you a little bit about what we're doing. But I'll tell you that there are labs, my lab and many's all over the country that are working on this. But that really comes from patients exactly like yourself being, so willing to give us those biopsies. All right, with that, I will wrap up and say thank you.